I'd like to talk to you about how we can actually change what's going on with fluid management. These are my disclosures. What we're talking about is something that's been dubbed fluid stewardship, which is very difficult to say. And basically what that is a whole hospital approach. So we want to standardize everything we can about fluids, not in terms of making a protocol, but trying to make things more consistent. That's including the assessment, the prescribing, the education, the numbers of types of fluid that we're using, and fluid balance charting. And this is a whole hospital system, really. Why do we want to do this? This is a paper from the BJA from 2015, and I really like this statement that unwarranted variation is a driver of waste and suboptimal outcomes in healthcare systems. If we're doing lots of different things in the same sort of situations, some of them must be wrong. And that paper was actually about anesthetic practice. It was in America, and it looked at the anaesthetists who were anaesthetizing fairly similar colorectal patients. And a patient with 400 ml blood loss in all these different centres in America might have got 700 ml of fluid in theatre, or might have got 9.7 litres. And they made the comment that the reason for the difference was nothing to do with the patient or the surgery, but it was just the anaesthetist. If we can do that really badly, then junior doctors on the wards who haven't had very good education about fluids will do it badly as well. I'm going to take you through our fluid journey in Fife, and it's really been my work for the last 13 years. I have just finished a quality and safety fellowship, and having done that, I realised that when I started this fluid work, I should have used something like this to guide the plan of what I was going to do. I didn't, but it can be kind of fitted into this, so I'm going to go through Cotter's steps with what we did in Fife. First one is you need to show that there is a problem and establish a feeling of urgency. So what are the problems with fluids? As Ash has just talked about, the clinical harm is the main reason we want to do something about this. But there's also poor education and lack of accurate fluid balance charting. We can show that there's clinical harm quite easily just by doing an audit in our wards. Probably if you show that you have a problem with 5 patients, it means you've got a problem. So you can just do really small audits in different areas. And we did that. And we showed that often we were giving too much or too little fluid, far too much sodium and not enough potassium. This is where I heard about this problem was in 2009, I was at a nutrition conference, and Professor Dilip Lobo, who's a surgeon in Nottingham, was presenting about saline. And he's done a lot of studies on that and written about abnormal saline. And he talked about the NCPOD report from 1999, which was 10 years before that, where elderly patients were dying as a result of too little or too much fluid. And it made the point that fluids were just as important as drugs in terms of prescription. And this is where we get the 1 in 5 people on IV fluids suffer morbidity or mortality. Paracelsus said this very useful thing, and he was known as the father of pharmacology. So whatever you take, whether it's too much coffee, too much chocolate, too much saline, too much glucose, it's going to be a poison. So we really need to do this carefully. We did a mortality review, and we found that about 13% of deaths not necessarily were caused by fluid management, but there was a contribution. It was particularly the frail elderly who were coming to harm, and there wasn't much senior input from consultants. And interestingly, if you were put on a fluid restriction of 1 litre, you would probably get about 200 mils a day. So you really have to say, I want this patient to have 1 litre, not I want them to be on a fluid restriction. So that was frequently associated with AKI. And that's a lot of harm. And we're constantly doing trials in ICU which have tiny little changes in outcomes. But if we can get rid of 20% of people having harm from IV fluids, that's a big change. Fluid prescribing, as Ashley has shown, if you have a blank fluid chart, it gets filled up with all sorts of rubbish. And I am equally guilty of having done this as a junior, just done what the last person did. And the nurses would give you a pile of fluid charts and say, can I have fluids for these patients? And you would just write something up. And you wouldn't know anything about the patient or what was going on. And this was in 2011 in Edinburgh University. Then we had a big report in Scotland, and that showed that fluid balance charting was poor throughout Scotland. If you're thinking about doing something like this, then how do you start? Well, if you don't have a guideline, who's going to do it? There's lots of staff turnover. You really need lots of education. There's lots of fluids being used, there's poor fluid balance charting, and then the consultants all say, oh, well, I've done this for years, I know what I'm doing. So it's difficult. So you really need to have a team. And this was our team, and I forgot to put on a biochemist on there, so they were really important as well. I would urge you, if you're going to do this, you need a renal physician, because people listen to them, and you definitely need a pharmacist. But you also need engagement from the medical director, because he's the key, he or she is the key to making sure that people know that this is happening and it's important. Then you need a strategy. And our strategy was really to get the guidelines out first of all, but I want you to think of what's happening in your hospital. Who's teaching fluid prescribing? Do we know what they're teaching about? Who taught them? And is it based on a guideline, or is it just something that they've picked up as they've gone along? And the comments from junior doctors are, everyone does it differently. I'm not confident. It's very confusing. I go to this ward, Dr. X says this, and I go to this ward, and Mr. Y says, oh no, don't do that. Give them all furosemide or something. So the juniors find it very difficult. Other questions that we need to ask is, what charts are out there? Are they all the same? We found that there were 3 or 4 different prescribing charts and fluid balance charts in our hospital. Is anyone auditing it? Who's controlling the fluid stocks? Again, we had different fluid stocks in all the different wards, and it was all just in boxes and very chaotically organised. We showed that we needed a guideline because we did the audits and they were bad. So we spoke at consultant meetings and showed that this was a problem and suggested that we needed to change it. And there was actually a lot of enthusiasm from the consultants in our hospital, particularly the surgeons. We used some guidelines from Southampton, and they had taken the Gift Us Up guidelines and made it into a little leaflet, which is like this. And I was kindly given this at a conference by Aminda de Silva, and they had introduced these guidelines for surgical patients. Later on, the NICE guidelines came out. So what we did was we developed this one, which is a conglomeration of all of that. The NICE guideline is 27 pages long, so this is much shorter. And it's for adults. I haven't tackled pediatrics because I'm not a pediatrician, and fluids in pediatrics are different. We looked at what's the right fluid. So the NICE guidelines suggest a low sodium fluid for maintenance, because if you're keeping yourself hydrated, you want to drink water, you don't want to drink saline. You certainly wouldn't drink seawater, and if you give several litres of saline, you've given a couple of litres of seawater. Replacement, we use a balanced solution, and resuscitation, again, we use a balanced solution. Saline we'll use in certain circumstances only, like vomiting when your chloride is low, or hyponatremia. And we insist on prescribing in mils per hour rather than hourly bags, 2 hourly bags, because if you use 500 ml bags or litre bags, that's a different rate. This is the fluid that we've picked for maintenance, and we've standardised that across the whole hospital. including for patients on variable rate insulin infusion, and the diabetic team's quite happy with that. There are other options. We give this by weight, so it's 30 mils per kilogram per day for fluid, and that there's a table for that on our guideline. So if it's maximum 100 mils an hour, so even if you're over 80 kilos, you get 100 mils an hour of maintenance. If you're 50, you might get 50 mils an hour or 65. I can't remember. There's a range on the chart. There's not much written about maintenance. Niels van Regenmortel's a Belgian intensivist, and he's actually done 2 trials on this, which are really useful. He's also written a lot about fluid creep in intensive care and hyponatremia, hypernatremia. And he showed that if you give maintenance as a balanced solution or saline, that's associated with more high fluid balances and hyperchloremia. But he also showed that low sodium maintenance doesn't cause harmful hyponatremia, and that's the concern that a lot of people have in using these fluids. The next thing is education, and I think that's really the biggest thing that we've dealt with, is ongoing continuous education of the leaders. We engaged with charge nurse groups and multiple education sessions for all grades of doctors and prescribers, and e-learning and induction. We talk to the junior doctors at induction every time. Then you want to have goals. So we want to improve prescribing, fluid balance, and rationalize the fluid use. When we introduced the guidelines, we discovered that actually people weren't following them because they might have this in their pocket, or they've probably left it at home. They haven't got time to look it up on the intranet. So what we decided to do was put the guideline at the point of care, and that was really a game changer. To do that, we employed a fluid nurse, and we also standardized the availability of fluids. This is one of our posters that's around the hospital. And the questions that are in the guidelines that you have to ask when you're prescribing fluids: does the patient need fluid at all? Maybe they don't need it. You need to assess the patient. You need to know your patient. Why do they need it? Is it for maintenance, replacement, or resuscitation? How much and which fluid? And our guidelines also cover these other aspects of fluid management in a bit more detail. The big difference when you're doing this properly, prescribing carefully, is that it's not so important for the 80 kilogram man if he gets a bit more. But for the 40 kilogram man or woman in hospital, if they get 3 litres a day, you're going to overload them very quickly. And if they get several litres all at once, you're really going to overload them. So we employed a fluid nurse from a research and development grant, and we still have one, currently Emily. Megan had a quality improvement background, and she was able to introduce our charts. And this is the prescribing chart, which has the summary of the guidelines at the top of the chart. And it really makes a big difference, so that when you're prescribing, you can refer to the guideline. We don't have electronic prescribing yet, but it will come, and then we'll have to rethink everything. Balance is very important, and you need to know what's gone in and out to prescribe safely. So on the back of our prescription chart is the fluid balance chart, and it's only for 24 hours, and it has a stop and check bit in the middle, so that at 2 p.m. the nurses can pass on any problems with the fluid balance before the doctors all go home at 4, and then there's nobody around. Well, there's the on-call team. We have boards in the ward just talking about fluids and the charts. We have criteria for fluid balance chart use. Not everybody needs one. There's a volume guide to help the nurses to fill in the fluid balance chart. And then in the stock rooms, we've made sure it's all nice and clear. And that's where pharmacy is really important. So they control the fluid supplies to the wards. They take notes that we've got charting of all the fluids, what's being bought, what's being used, so we know what we're using in Fife. We've also looked at IV lines and standardizing those, and we're involved in procurement of pumps as well. We report incidents for fluids on day ticks. And then obviously we're trying to standardise education as well. So the next thing on the Cotter's 8 steps is sustaining. And we're now involved in lots of things in the hospital. So including fluids and IV lines, we're also involved with AKI work. And we've got partially involved in vascular access as well, which takes up some of the fluid nurses' time, unfortunately, but we're working on that to get a vascular access service. I have to do a clinical governance report once a year, and we do regular audits. Pharmacy is involved in responding to problems with fluid availability, like plasma light wasn't available for a while, so we went back to Hartman's, which is fine, and they do all the monitoring and ordering. We've done some audits, so this is one of fluid prescribing in 2019, and we found that 97% of prescriptions were following the guidelines, and most of them were also in mils an hour. We've also looked at how the junior doctors feel, and most of them, I do it sometimes when I'm teaching, I have a questionnaire before the teaching. So you could see most of them felt they had good training, the fluid charts were useful, and they were more confident. And also they routinely check the U's and E's before prescribing fluids, which is a really good thing. This is some more comments from a different junior doctor survey, and clearly it's made a difference. And I have a lot of junior doctors coming and saying, we really like the guidelines, we really like the charts, it's been so good working here, I wish it could be like this everywhere. The other thing was cost. So this is how I managed to get a fluid nurse permanently, because I went to the management and said, we've actually saved a lot of money on fluids. If you compare it with when we started in 2009, just talking about it reduced the amount of fluid that we were giving even before we introduced the guidelines. So as soon as they saw that we were saving money, they actually funded the fluid nurse, who had been previously funded from a research grant. We've written a paper. This was published, unfortunately got delayed by the whole COVID thing. It didn't have COVID in the title, so it took a long time to get it published. But we actually had over 30,000 patients that we looked at the biochemistry before and after the guideline went out. We found that there wasn't any significant change in electrolytes apart from, I'll go to the next one, acidosis. So we reduced saline use by 75%, normal saline, and you can see that acidosis dropped, and that was a significant result. So it dropped from 7.2 to 4.8% of patients. And we were looking at electrolytes in patients who'd been in hospital for more than 2 days. So it was a development of abnormalities rather than coming in with an abnormality. In terms of fluid use, you can see the black line is saline. A is 2009, when we started talking about fluids. B is when the guidelines came out, and then we started to focus more on potassium, so people were prescribed the maintenance fluid without potassium, and we did a campaign to increase the potassium use. And that's where the red line has gone up a bit more. So you can see there's quite a big change in fluid use. There are some difficulties in doing this kind of work. It is difficult to show clinical improvement if you don't have a big team of researchers looking at outcomes. For the juniors, having time to prescribe carefully is important. Getting the seniors to be involved as well, and then the turnover of staff, you keep having to teach more and more and more. The last thing is incorporating this into your culture. So for us now, the fluid teaching is routine. The guidelines are given to everyone. The charts are everywhere in all our 5 hospitals, and the permanent fluid nurse. And we've also got a national improvement programme. And one of the ideas of that is to try and standardise education in the universities. We're not quite there yet. COVID obviously got in the way of progress. But up till COVID times, we were meeting regularly. We had all 31 hospitals in Scotland, major hospitals taking part, and national pharmacy figures. And there's lots of fluid staff now, so there's fluid nurses in several hospitals, and this was funded by the Scottish Government, but we're hoping that the hospitals will then start funding it themselves. This is the pharmacy figures hospital medicines utilisation database. It's called HMUD, and you can see that in 2016 we were using the least saline out of all the hospitals. We were using the most potassium, and other hospitals were using litre bags as well, but we've increased on that as well, and that reduces nursing time and saves money, but you have to watch about the 4-hourly prescription. And with the programme, you can see, if you look at these figures, the saline use is decreasing across Scotland. The amount of potassium being used is slowly increasing, and the use of litre bags is also increasing. So there's ways of monitoring what's happening in a nation when you change things. I think without COVID it would have been a lot better, because some of the staff doing this were taken away from their posts. So my take-home messages are that patients do come to harm from excess or inadequate fluid, and the important thing is not having a protocol but getting the right amount for that patient. Using guidelines, educating and standardising should prevent much of that 20% harm. It can be implemented safely, as we've shown with our study, but it does require teamwork and time. Thank you very much.